Hi, and welcome to the show. Rate and review at kevinmd.com/rate. Subscribe at kevinmd.com/podcast. Today, we welcome back on the show Diana Girnita. She is a rheumatologist, and she's the founder of CEO of Rheumatologist OnCall. Her KevinMD article is titled, Why Expand Telemedicine for Arthritis Patients? Diana, welcome back to the show.
Thank you so much for having me back, Kevin. It's a pleasure to be here.
So we'll get into the article in a little bit, but for those who didn't listen to our first episode, I was about to say about a year and a half ago, just briefly share your story and journey to where you are today.
Yes, so I'm a rheumatologist. Currently, I'm based in California, Irvine, California. And about 3 years ago, I started my journey as an entrepreneur, physician's entrepreneur, to build up a telemedicine company that will offer patients access when they need it the most. And I use telemedicine to approach the access to medical care, and I expanded from one state to multiple states, now active in 8 states across the United States.
Wonderful. And when we think about these telemedicine practices, we often think about either primary care or urgent care, but you're doing it in the specialty of rheumatology. So how have the last few years gone?
I think there is this misconception that as a specialist, you cannot pursue telemedicine, or it's harder to pursue telemedicine. But I'm here to prove that it's possible. And I'm here to prove that after 3 years of practice, the practice is growing. And this is a valuable tool, both for physicians, but also for patients, and especially for patients.
So in terms of people that you get referrals from, or where do you find patients, or how do patients find you?
I think, the misconception as a specialist is that you have to have referrals, or patients has to be referred to you. And that was my initial approach to call my colleagues and tell them about my services. And they did try to refer patients, and I have patients referred from colleagues, but most patients in our days are very proactive to find solutions for their problems. And, somebody said at some point, patients are not like sitting ducks. That's very true. Patients are actively searching for solutions because of the lack of access, because my specialty is one of those specialties where you have to wait between 4 and 6 months to see a specialist. Can you imagine a patient in pain, severe pain, to wait for 6 months to see a specialist? Or can you imagine a patient that is told you might have lupus or you might have rheumatoid arthritis to wait for 6 months? They will not wait. They will find solutions. So patients will find me, and Google is the best resource for our patients.
And before we go into your article, just tell us, what are the most common conditions that you typically would see in your telemedicine?
So in my specialty, I see a lot of people that are referred to me for abnormal labs, like a positive ANA. That's very, very common. But I also see patients that they have rheumatoid arthritis, psoriatic arthritis, many of them, Sjogren's syndrome, and polymyalgia rheumatica. A lot of, as I said, a lot of positive tests. I don't know what is this or what is that. So those are the common pathology that I see. And from time to time, I would see a patient with vasculitis, which, is stressful, but you do see those patients showing up.
All right, we're going to talk more about this in your KevinMD article. It's titled, Why Expand Telemedicine for Arthritis Patients? Now, how did your article come together?
So I have seen a lot of fear from my colleagues about offering telemedicine services. And when I look at patients with arthritis, and I want to refer to my specialty because here I know the most, you probably know, or for those that do not know, there are many, many people with arthritis in the United States. It was estimated that last year were about 62 million, and this number is going to increase. In 2040, the CDC is saying that they're going to be about 78 million people with arthritis, just arthritis, not autoimmune diseases. So I thought about, there is a huge need to serve these people. And on top of that, many of us, we are about 6,500 rheumatologists in the whole United States. And most of us, we are located in the big cities, metropolitan cities, on the West Coast or on the East Coast. And in the middle America, north side or south, there are very few specialists located. So what is going to happen with these people? How are they going to access proper care, specialized care? So I saw telemedicine and, expanding this idea and putting this idea in front of other physicians as a valuable solution for our patients that are in need.
So, in a typical rural setting, give us an example of one of those patients who came to you, and give us an example of the shortages of rheumatologists that this patient may have encountered before seeing you.
Oh, yes. I have so many of these stories. You would be surprised to see that, the patients are so limited in their access to medical care. I have this patient. He was a young guy. He was in his 40s with a lot of joint pain, and he tried to get help from his primary care physician, who gave him a referral. He went to, insurance panel. He was trying to find someone. He called every single doctor in his area, and they were not able to see him for about 6 months. And then he looked in 100-mile area radius, and again, he called, and most of these practices were not taking his insurance. So that was another type of limitation, or they were not able to see him, period. And his wife went online, search for a rheumatologist online. They found my practice. They read about the practice, but they couldn't believe they could be seen in less than a week. And the wife called, and my assistant gave her information, and then the gentleman called, and we gave him information. He researched my name. He researched everything about me. He knew everything, where I was, where I trained, because he could not believe he would be able to be seen in such a short amount of time. And I've seen him. I made a plan for him. We ordered tests. We ordered everything that we have to do. And in 1 week, he was on treatment. And in 2 weeks, he was back to his normal life. And this is only one story from many of the stories that I will give you.
So, take us into one of your virtual sessions. So, this gentleman, for instance, meets you for the first time on some type of virtual platform, I assume.
Yes.
Take us into, without giving out too many details, but take us into what that session is like, how long it'll take, what kind of questions you ask them, how would you examine virtually. So give us an idea.
Sure. So my sessions, my new patient encounters are 60 minutes. And during that time, I do a very, very thorough evaluation of where he was, what kind of symptoms he had. And it's a normal, typical conversation, but in a more relaxed environment, because most of the time those people are in their own house and they feel comfortable. They don't feel stressed. They don't see the white coat. They don't see other people gravitating around them. They see me, and it's a very intimate, I would say, relationship, because that's only the patient and the doctor, and you don't have the stress, the environment around you. And then the exam, it's always done. The physical exam, I do the physical exam, and maybe you would say that yeah, that's a limited exam, but you can still see, if you point your hands to the camera, if you ask the patient to do certain moves, if you distract the patient also with do this, but you talk to them, you will realize that what they do is, it's basically what you would do with the patient in the exam room, in the typical exam room. And then you make the plan. I order the test, I order imaging, whatever they are. I am able, because I have a national contract for labs and for imaging, I can order tests for them, and they can do it where I have contracts, or they can choose whatever they want to do their labs. I can fax the orders there, and it is done. And then, when the results are ready, the patient comes back and we make the plan again. So it's very, very similar with what you do in real life.
So what about medications? If you need to prescribe immunosuppressants, if you need to prescribe steroids, anti-inflammatories. So what's the limitations there, if any?
I don't see any limitations. If the patient needs a medication, I would send the medication to whatever pharmacy they have. Or if I need to approve a medication, I will take their card, I will contact their insurance, I will approve the medication. I will do the exact work that I will do in, the typical practice that we have. There's no difference. The only difference is that you don't touch the patient
Mhm.
and they are not able to touch you. I mean, that's the only difference.
Now, what are some of the barriers of other physicians? Like, why don't more physicians do a virtual practice or a telemedicine practice like you? Well, what are some of the barriers that face the majority of physicians today?
I think the major barrier for most physicians is this fear of liability. And not only that, but there are physicians, believe it or not, that they are afraid of new technology also. And, in the beginning of telemedicine, and telemedicine is here for 20 years already, but let's say years before the pandemic, the other limitation was the fact that they could not collect payment from insurance companies. And I'm going to tell you that I had a discussion with my former employer, and I was presenting them telemedicine as an option to optimize care, especially in patients that they had to travel 2 hours to see me, where I would do the exact thing on telemedicine. In 5 minutes, I could have done that.
Mhm.
Then the patient traveled for 2 hours to see me. But the fact that they could not collect payment from the insurance companies they couldn't bill, that was a huge limitation. And the other big limitation for physicians in our days is that they have license in only one state, or they have non-competes that will not allow them to
Mhm.
cross that area where they are. And the license problem is huge for many of us.
Now, do you accept insurances or are you under some type of direct pay model?
My practice is a direct specialty care model where I contract directly with the patient, and if the patient wants to take the invoice, reimburse it through their insurance, they are more than welcome to do that. Or if the patient wants to use their insurance to pay for laboratory services, medication, imaging, they can do that, but they can also have the ability to see the cash price that I can offer. And I think I told you that before, but I'm going to reinforce that. Initially, patients would not believe that the cash prices that I offer are smaller than they would get if they go through their insurance. But actually, there are many times, 10 times smaller, because after you pay the copayment and the insurance pays a part, you are still responsible to pay 20% of that bill. And then 20% of $1,000 is different from 20% from $100.
How about a response from your colleagues? Do you get any response from your fellow rheumatology colleagues? Do they raise their eyebrows or or are they wholly supportive of what you're doing?
I think there are, on both sides, and it's absolutely normal.
Hmm.
But I see them embracing telemedicine more and more and more. And, once they see you validate a model that is working, now there are so many other people that are calling me and asking me, how can I do this? Is this possible to be done? Where are the patients coming from? How do you do the contract? So I have tons of questions. Every week I would get emails from rheumatologists across the United States to ask me if they can do that in their community, or if they can do this as a practice in multiple states.
So take us in that direction. So let's say a rheumatologist calls you and wants to do something similar to what you're doing. What would be their next steps, or what would be some questions they need to ask themselves to make sure that they're the right person for this?
I think that the first question is, do you really want to do this? And why do you need to do this? Or why do you want to do this? I think in your shows, I've seen many times that physicians are burnout.
Mhm.
Physicians are looking for ways to continue to practice medicine in their own terms. And I'm going to tell you a story. Over the years, I have been the mentor of many, many medical students, residents, and I have promoted many of these residents into rheumatology fellowship. And I'm very proud that these people got into rheumatology. I infused this passion towards, practicing rheumatology in these people. And yesterday I got a phone call from one of my former mentees, and he is in practice as an attending physician for 1.5 years, and he feels already burnout,
Mm.
and he doesn't like what he sees, and he's looking a way to get out. So we had a long discussion about what I'm doing, what he can do. And I was trying to convince him to remain in medicine because, I know there were 100,000 physicians last year that left medicine. Who's going to treat us in 5 years or 10 years? And, it's such a pity because all these people, they invested so much time, so much effort, and they had the passion to be there, to be doctors. And now they feel defeated. And this is not what I want to see, and not even for my kids. One of my children wants to go to medicine. And, I don't want to stop her from doing that. I want her to believe in that. And, like me, I'm the only doctor in my family, and I was the first doctor in my family. I had so much passion about doing medicine. So I want that to be preserved. And I want those people that got into medicine to be physicians to remain there and continue their mission.
So just give us an idea of the scope of specialty direct practices. How many of you are there in the country?
There are many. And I have to tell you that about 2 years ago, I started an organization called Direct Specialty Care Alliance. And the scope of that organization is to help other physicians understand the model, be able to practice as a direct care practice, and expand this idea that you can still practice medicine in your own terms. That's for physicians, but also give patients access and the right or the quality of medical care that you want to give. And this organization grew very much. And right now, I think there are more than 100, if not more, practices, direct specialty care practices. And many of these people, they got help or they got the idea from us. And this is amazing, because you not only that offer them a solution, but you offer them the support. And I have created also a map. We have this map on our website, dscalliance.org. And every week, you're going to see their practicing popping up across the country. And this is absolutely great because when I started this 3 years ago, I had no idea about anybody practicing this in the country. As a specialist, as direct primary care physicians, I knew many. But as a specialist, I had no idea where to look for my peers or where to find resources for specialty care.
Now, what other specialties are there other than rheumatology?
Yes, many rheumatology, but there are nephrology, cardiology, allergy, pain, regenerative medicine, hematology, podiatry, many podiatrists, orthopedics, and what else? I have to think. There are many, many, many specialties. So basically almost from each specialty, we have someone.
We're talking to Diana Girnita. She's a rheumatologist, and she's the founder and CEO of Rheumatologist OnCall. Her KevinMD article is titled, Why Expand Telemedicine for Arthritis Patients? Diana, tell us some of your take-home messages that you want to leave with the KevinMD audience.
So I would like to say that telemedicine is here to stay. Telemedicine changes lives, and telemedicine makes the care of the patient fast, convenient. It's very comfortable for patients, and it's also safe for patients, and it will allow every American to receive the care that they need when they need it the most. That's very important. So I would say that we have to ask, the federal government and whoever is out there that could help us and help us to lead this path to future healthcare, incorporating telemedicine as a viable solution for our patients. Thank you.
Diana, thank you so much for coming back on the show and sharing your time and insight.
Thank you so much, Kevin.